Welcome to another EduMed video, and in this video we'll be talking about using anaesthetic machines as ITU ventilators. What we want to try and do in this video is to highlight some of the issues with using anaesthetic machines and some of the cautions about where we can sometimes go wrong and cause harm to patients when using the anaesthetic machine without appreciating just how different it is to an ITU ventilator. So, in the first part of the talk, we'll highlight the differences between an anaesthetic machine and an ITU ventilator, and then we'll talk a little bit about about different aspects of an anaesthetic machine that you should be aware of and cautious of. I hope this is a useful video, not just for doctors, but for nurses and for physiotherapists and others who will be dealing with these intensive care patients. And certainly with the recent lack of ventilators that are available, lots of patients will be on anaesthetic machines. So the first thing to say is that anaesthetic machines are not intensive care ventilators. The newer generation of anaesthetic machines certainly are starting to mimic the ITU ventilators, and some ITU ventilators are basically being repurposed into anaesthetic machines. So some of the new Draeger machines and the McKay machines are essentially ITU ventilators that they've just tagged on the bits that you need for anaesthesia. But certainly the older anaesthetic machines and the ones that are more commonly used in anaesthesia at the moment are very different to those of the modern day intensive care ventilator. So you need to be really careful when you're thinking about ventilator synchrony, and certainly you will find that patients do not synchronize as well with the anaesthetic machines as compared to the ITU ventilators. And so for spontaneous breathing and pressure support, it may be more difficult to wean patients on anaesthetic machines as compared to ITU ventilators. The modes of ventilation may be slightly different. Generally speaking, in anaesthesia, we paralyse our patients or have them under a deep plane of anaesthesia, and so we don't often have them spontaneously breathing. As such, a lot of the older anaesthetic machines just have a pressure control and a volume control mode. Some of the newer ones have the new modules which allow for a pressure support, and so the spontaneous breathing of patients, and then allowing for the ventilator to give a bit of additional support when taking those breaths. But it should be noted that the way in which the pressure support works in an anaesthetic machine, especially the older ones with the bellows, is not the same as the new modern day anaesthetic intensive care machines or the new anaesthetic machines. So one of the big fundamental differences between an anaesthetic machine and a intensive care machine is that an anaesthetic machine usually has a bellows, and you can really think of it like handheld bellows. What the ventilator does is it just pushes down so the gas that's in the bellows gets shot out. And you can think of this entrance of air as the gas being provided into the ventilator. So it blows up the bellows, and then all the machine does is it pushes down to expel the gas that's already in the bellows out. An ITU ventilator does something slightly different. It uses pistons, and this is the cylinders that you see in a car, but it's very similar to what you see inside an intensive care ventilator. And what this does is that it pushes air out, and then it comes back, provides a negative pressure, and allows gas to fill in again. Now that might seem like it's not very different to the passive flow of gas coming in with a anaesthetic machine, but it is different, because if you imagine that not enough gas has come into this bellows, then the ventilator will not be able to provide a breath, because there's not going to be enough gas for it to push down and expel out. Whereas with a ITU ventilator, you're going to guarantee the volume by bringing this piston down each time and therefore actively filling this chamber with gas that can then be expelled out during the inspiration phase of the ventilator. So you can get much more guaranteed volumes of gas when you're using a intensive care ventilator, and also your pressure modulation is slightly more accurate because you know the dimensions of this piston, you know the amount of time that the piston has gone down, and you know the size of the chamber. And so you can vary these things with great accuracy. With the old, what we call bag and bottle, or the bellows method of the anaesthetic machines, it's a lot less accurate to be able to do this. Also, with this bellows system, if a patient takes a breath in, the ventilator has to detect that a breath has been attempted and then to push down on the bellows. This can lead to a lag time, and so patients may not actually get the increase in pressure that they need when they need it at the start of a breath. Whereas with these piston methods, as with an intensive care ventilator, we do see much more accurate provision of a breath whenever a patient is spontaneously breathing and tries to take that initial inspiratory effort. Aside from the way in which the gas is delivered, i.e. a bellows versus a piston, the anaesthetic machine circuit itself is fundamentally different. And the reason for this is in anaesthesia, we try to use the lowest amount of gas possible, and that's because we're usually trying to keep patients asleep by using vapours, things like sevoflurane, isoflurane. And if you have lots of gas flowing in, you're going to waste a lot of the volatile agents like sevoflurane and isoflurane. And if you've got an operation that's lasting 10, 12 hours, you don't really want to be going through lots and lots of bottles of vaporizer and wasting a lot of it into the atmosphere. So the way in which an anaesthetic machine is formed is the so-called circle system. So if you look at just this bit here, this is all effectively a circle. What happens is that you get a little bit of gas coming in, and this is usually oxygen with a bit of air, and this is providing the oxygen into this circuit. The patient, as the metabolic activities are occurring, are going to be consuming lots of oxygen. So you need to be able to match the amount of oxygen that's being consumed by putting a little bit of oxygen in each time into the circuit. And then, when the patient breathed out, what it's going to be breathing out, this grey dots, this is carbon dioxide. Because this is a circle and the patient's just going to keep breathing the same gas again and again, except for a little bit of oxygen that's flowing in to supplement what's being used up by the patient, we need a way to get rid of the carbon dioxide. And so what happens is this carbon dioxide comes out and then goes through a something called Sodalime, and this basically absorbs all of the carbon dioxide so that what's left is just oxygen and the anaesthetic volatile gases. Now the reason it's really important to understand that we use low flows, that we're rebreathing all of this, is that it means that it's slightly different to the intensive care ventilator. In intensive care, it's really simple. You have an amount of oxygen that's coming in, and you have an inspiratory valve, and it just pushes the air in. You've usually got some kind of humidifier to keep the gases nice and moist so that the secretions inside the lungs don't get too thick and difficult to aspirate. So it drives this gas in to the patient, and then as the patient exhales, it drives it out. And then this just gets exuded out into the atmosphere through a variety of filters to get rid of any virus particles or bacterial particles that might be there. So you're constantly getting new gas coming in and constantly pushing out the old gas. So rather than rebreathing the gas that you have been breathing out, this is fresh gas all the time. The reason this is important is that you don't need to have things like the Sodalime to absorb the CO2, and also you're using higher flows of oxygen and gas to make sure that the whole system remains flushed throughout the respiratory cycle. The anaesthetic machine itself looks very different to the intensive care machine, and this is just a schematic from MedGadget which just gives you an idea of what you're looking at. Now obviously each anaesthetic machine looks very different. This is a Datexometer ventilator, quite an old one, but one that's very commonly used still in intensive care, in anaesthesia. For the intensive care patient, you may not have these vaporizers. It depends on whether we run out of things like propofol, in which case you might need these vaporizers to try and keep patients asleep and not waste as much of the propofol for other patients. Now, we talked about the bellows, and this is what this is. This bellows assembly is essentially a bag that moves up and down inside a clear plastic chamber. So you can always see this bellows going up and down. At the point of expiration, at the end of the expiration, you should expect this bellows to be right up at the top. If it's not reaching right up to the top, there is a leak in your circuit and you need to look for that, because especially when you're using lower flows, you may find that the bellows starts to drop and drop and drop to a point where the ventilator can't actually work anymore because there's no gas in the bellows in the bag to push down on. The display is really important. This will tell us what the amount of oxygen that the patient is getting, the amount of carbon dioxide that's coming through, the pressures that the patient is seeing from the ventilator. So all of the displays are usually on here, and we sometimes have a slave monitor on top as well, which gives you some additional information. Now, the carbon dioxide absorber usually sits at the bottom of the ventilator circuit, which connects here. And this is the bit that can fill up with carbon dioxide, and so you need to have a look at that, and we'll go through that in a bit of detail later. At the bottom here, you will see a number of dials, and this is really telling us our gas pressure. So usually the mains gas, for the wall gas, is seen here. And on the back of an anaesthetic machine, you often have some auxiliary gas cylinders, so some oxygen cylinders, just to make sure if you do run out of wall gas, which can happen in this day and age with such high oxygen demands, you can then switch them over to the auxiliary gas, which is the cylinders which are attached to the back of the anaesthetic machine. And then the final thing that's worth looking at are these flow meters. You will often have an oxygen flow meter, an air flow meter, and a nitrous oxide flow meter. For intensive care patients, pretty much avoid this nitrous. You don't really need it. But what you will need is the oxygen and the air. And by changing the amount of flow of each of these, you can adjust the fractional inspired concentration of oxygen. For example, if you have 2 litres per minute of oxygen and 2 litres per minute of air, you're going to get roughly about 60% oxygen. Why is it not 50%? Well, air has 21% oxygen in it already. But it's very difficult to really know how much oxygen you're giving, and that's why looking at the display is so important, because it'll actually give you what the patient is seeing, the inspired fraction of oxygen. So don't go by what the flow meters say, go by what the monitor says, and if that shows that the patient has got a fractional inspired concentration of 30% and you want to increase it up, increase the flow of oxygen till you get to the point that you want. You will see that there is a bag here. For the purpose of intensive care, forget about it. This is a bag that we use to manually ventilate patients, which you sometimes do initially when you're intubating a patient, or sometimes when you're starting to try and get them to breathe for themselves once an anaesthetic is finished. That is not going to be the case in intensive care, and you're not going to be putting patients on spontaneous modes of ventilation through this circuit. So I wouldn't worry about it. The other thing just to bear in mind is the oxygen flush. And these are usually on the front of the machine. I'll show you a picture of it a little later. This is essentially flushing oxygen at 60 plus litres per minute through the system, and it's 100% oxygen. So you can imagine if that rate of flow, you're going to get a high pressure. And so if you keep pressing this, the patient's lungs will see that high pressure, so you can potentially blow a pneumothorax. So be very careful when pressing the oxygen flush button. When would you need the oxygen flush button? Well, if this bellows has slowly dropped down because there's a leak in the system, there will come a point where the bellows are collapsed. So the ventilator can't actually give any breaths because there's no gas in the bellow for it to expel out. And at that point, the ventilator will start alarming, the patient won't be getting any breaths. So if you want to rapidly fill this bellows back up again until you address the problem with the leak, you can press the oxygen flush button and then get the bellows full and then sort of try and work out where the problem is. So a few cautions with anaesthetic machines. This is just a closer view. This is actually a veterinary anaesthetic machine, but it's the same sort of thing. You have a bottle and you have a bag that goes up and down. If this bag is collapsed, as you can see here, there's no gas for the ventilator to push out, and so it just won't do anything. So what things can cause the bellows to empty? This is the thing I really want to emphasize in intensive care. We quite regularly suction patients if they've got secretions. And in an intensive care machine, it doesn't matter because it's constantly providing new gas. Whereas in anaesthetic machines, because you're rebreathing the same gas, if you put a suction catheter down, you'll see this bellows rapidly drop because you're sucking all of the gas out of the ventilator circuit. The other times that you can do it is by breaking the circuit. So sometimes if you're putting in nebulizer units, it can break the circuit. Or if you've got an accidental disconnection, and the common places for disconnections are at the site of the machine, the site of the patient, or in some of the tubing that you've introduced in, for example, the HME or the humidifying wet circuit. The other thing that's really important to bear in mind if you've got a slow leak, and the way you see a slow leak is that the bellows will slowly drop and drop and drop. At the end of expiration, you would expect this bellows to go right up to the top. If it hasn't, then there's a leak somewhere. And sometimes if you don't have enough pressure in the endotracheal cuff, or you've got a leak because the cuff just is broken, then you can potentially get this bellows slowly dropping down. So always think about your endotracheal tube, check the cuff pressures, and check that the patient hasn't accidentally extubated themselves or partially extubated themselves. So what do you do if you find that the bellows has dropped down, the ventilator is alarming, and you can't get a breath in? Well, there are two things that you can do. The immediate thing is you can press the oxygen flush button. And by pressing that oxygen flush button, you will rapidly, 60 litres per minute, fill that bag up again. If there's not been a complete disconnection of the circuit. Or you can increase the flows. So you can turn up your oxygen flow rate, your air flow rate, and then fill up the bellows that way. And that's a slightly safer way of doing it, because then you're not getting the high pressures from the 60 plus litres per minute that the oxygen flush would do. However, it takes a little bit longer to just turn up the flows. So if you're in an emergency, press the oxygen flush button. Don't keep hold of it. As soon as you've filled up that bag, let go. Don't use the oxygen flush button to pre-oxygenate a patient before suctioning them, because as I said, you are getting a very high pressure. So if you want to pre-oxygenate a patient before suctioning them, using the flow meters, turn down the air to 0, turn up the oxygen flow rate, and you are going to get 100% oxygen going into the patient. If it's an electronic system, just dial the oxygen fractional inspired concentration up to 100%. Don't use the oxygen flush button to pre-oxygenate patients. You can cause pneumothoraces. So what does the oxygen flush button look like? Generally speaking, it looks like this. It's on the front of the machine and it's slightly recessed in. And you just press it in and keep hold of it until the bellows is filled up. The flow meters look like this. So generally speaking, the oxygen flow meter is often on the extreme left as you look at the machines and has this indented rotometer. And the dial is indented only because if, for example, there's a power cut, you can't see what's going on with the machine, you can always feel for the oxygen and turn it up. but it's useful if you're just feeling it. The only one that you should really be adjusting is this one, which is the oxygen, and next to it there'll be an air flow meter. Now blue is nitrous, so I suspect this one is a nitrous. You don't need to use this. This is an anaesthetic gas, and it's not really used outside of anaesthesia. And next to it is air. Now, in order to adjust your fractional inspired concentration of oxygen, it's not like in a ITU ventilator where you just dial in the number. Here, in these old machines, you have to adjust the flow rate of air and oxygen. And so by increasing this, or decreasing your air amount and increasing your oxygen amount, by changing that ratio, you're going to change the fractional inspired concentration of oxygen. And this is, again, what we're seeing here. So if you want to change the amount of oxygen with this system, increase your oxygen ratio compared to your air ratio. Don't touch this blue one. You don't need it. It's used as an anaesthetic. On the slightly newer machines, you get a picture like this, and this is a Draeger machine, but the Mackay system is fairly similar. And what you can see here is you can set your oxygen amount, so 50 litres, and here you've got 1 litre per minute going. What I want to really emphasise to you is what you are setting here is not what the patient is seeing. Look here at the gas analyzer and look at the oxygen amount. So even though I've set 50 litres per minute, or 50% oxygen going in as the gas, the patient is only seeing 41%. So when you are monitoring the patient and seeing how much oxygen they're on, don't look at this number. Always look at the inspired oxygen amount by the gas analyzer. That's the accurate one. Now you might ask, why isn't it giving 50% if I've set it to 50%? Well, if you think back to that first diagram, the circle system, what we're saying in this ventilator is we're giving 50% oxygen into that circle system at 1 litre per minute. So it's diluting up in the whole amount of gas that's in the circle system. So if that whole system has, say, 4 or 5 litres of gas in it, and you're just putting in 50% oxygen into a litre of that 4 or 5 litres, obviously you're going to be diluting down the amount of oxygen that's in there. So at these low flows, you need to be very careful about what you're setting here. And you might be setting a setting here of oxygen of 100%, but actually only getting an inspired oxygen concentration of, say, 50 or 60%. So always look at the gas analyzer. Do not worry about what this is. You change this up and down to get what you want here, the inspired oxygen amount. So I just want to reiterate this. Do not look at the amount of oxygen that you're setting. So here, 90% has been set, but if you look at the fractional inspired concentration, it's only 85%. And similarly here, we've set 50%, but all you're getting is actually 40%. So always look at the gas analyzer. Don't look at what you've set it at. They are not always the same thing. Now, in terms of the amount of gas that you use in an anaesthetic machine, I would suggest always keeping the flows above 5 litres per minute. So just to go back, here is the flow rate that we're setting. And here, because this is an anaesthetic that they're providing, they're using a low flow, so only 1 litre per minute. Change this value to 5 at least in patients. The best rule of thumb that I can give you for patients on the intensive care is try and use 50% of the minute ventilation. So if the patient has a minute ventilation of 12 litres per minute, then give them at least 6 litres per minute into the system. That'll prevent a degree of rebreathing of gas, and it'll also allow you to make sure that there aren't any leaks. If there are leaks, if they're small, it's not going to be consequential, and you're going to be able to wash everything out appropriately. And it's also important in terms of trying to keep your Sodalime, so what's absorbing the CO2, from not running out too quickly. You should be careful because patients who you will be looking after in intensive care are going to be hypermetabolic. The average oxygen consumption for a 70 kilo patient is between 200 and 300 mils per minute at rest, or at low rest. So generally at an anaesthetic level. The intensive care patients, however, are going to be hypermetabolic, and you can sometimes see patients with over a litre per minute of oxygen requirement. So you need to make sure you're providing enough oxygen, so enough flow of fresh gas to be able to cope with that huge amount of oxygen consumption. And by using these higher flow rates, you're not going to run into a position whereby you're consuming more oxygen than the machine is putting into the gas circuit. The only thing I would say about high flows, so the 5-6 litres per minute, is talk to someone before you do it in someone who is being kept asleep with a gas anaesthetic like sevoflurane or isoflurane. And the reason for this is you're washing out the gas so quickly that you're going to end up using up huge amounts of isoflurane or sevoflurane. And so for those patients, sometimes you need to use lower gas flows, but if you're doing that, there are all the problems that I described before. So just be very careful, speak to someone, an anaesthetist or an intensivist, before you change the flow rates. If a patient is on sevoflurane, isoflurane, or any of the other volatile agents to keep patients asleep. Now, in anaesthesia, we generally don't use wet circuits because there are shorter periods of time that patients are ventilated compared to intensive care. And HME filters are used quite a lot. This is heat and moisture exchange filters. The filter itself contains a hygroscopic material that captures the moisture of the patient's breath as it comes out. And so as new gas flows through it, it humidifies and keeps that heat from the breath that came out and transfers it into the breath that goes back into the patient. This is generally what these look like, and you have to be very careful about using these for long periods of time. These can fill up with sputum or with lots of fluid if the patient has got a lot of insensible loss of water through their respiration. And so you can get flooding in these. And the first signs that you might be getting into these problems is that the patient's peak pressures or plateau pressures start to just slowly go up and up and up. And the reason for this is that you're increasing the resistance through the HME, because it's basically just a load of paper in this part of it, and if that gets sodden and if it gets completely blocked with water, you can't get gas easily going through. So if you get sputum or water going into these, and they're usually clear so you can see, change it. If you are changing these are your bacterial and viral filters. So you must make sure you clamp the tube if you're going to take this off, because the end that's connected to the patient here, this is going to be full of viral particles. Now, most of these HMEs have a little green port here, and the reason for that is that in anaesthesia we connect it up to a gas analyzer, usually a CO2 and volatile gas analyzer. Sometimes this can get dislodged open, and that can provide a leak out of the circuit. So if you start to see your bellows start to drop, always have a think about this green cap here. Has it accidentally come off when people have been manipulating the tubing? Now, in intensive care, we often use wet circuits. So this is wet humidification and warming of the gases that go into the patient. if you are using a wet circuit, and most patients with viral pneumonia such as COVID, we're going to also be using a filter to prevent viral particles from coming out into the environment. Be very careful, because that wet circuit is going to be increased humidity coming in, and that increased humidity is going to cause flooding of this, and again the same problem of increased pressures and an inability to efficiently ventilate the patient. Now, we talked about the circle system as a way of rebreathing the same air to try and be as efficient as possible with the volatile anaesthetic agents that we're using. So you'll see these things here. This is called Sodalime. It's either white or it's pink, depending on the brand that you're using. And what this does is that the gas that the patient breathes out will come in, move around here, and then come out again. By doing so, these little pellets will absorb all the carbon dioxide up and produce water and heat in exchange. So it's a good way of keeping the inspired oxygen nice and warm and moist. And it also gets rid of all that carbon dioxide, so you can keep rebreathing the same gas without the CO2 slowly going up. But this is a consumable item. Over time, you can see here the white is normal, and it goes pink as you're using more and more of the Sodalime. And this is what you're going to see. So if you look purely at the end tidal CO2 graph, so without looking at the numbers, here it's going back to zero because all of the carbon dioxide is being absorbed. All of it's being absorbed. But at this point, we've suddenly exhausted our CO2 absorbent, so the Sodalime. Can you see here how now the amount of CO2 is slowly increasing up with each breath? And that's because there's CO2 remaining in the circle system. So with the next breath the patient takes, they're breathing in some of the old CO2 from the last breath. And so you'll see that the amount of inspired carbon dioxide comes up. And so you can see that on your gas analyzer. And again, really important to always look at your gas analyzer. You'll get an end tidal CO2, which we're all used to, but the thing to look at is your inspired CO2 level. And generally speaking, most people try to keep it below 0.3 kilopascals. If you are starting to get higher levels of end tidal CO2, you will find that your PCO2 is starting to go up as well. And if it does do that, then it's really worth changing that immediately, because you will otherwise get into problems. If you find that your your inspired CO2 is going up, and there's a bit of a delay in trying to get a Sodalime to be changed, the other thing that you can do is flush out the system with each breath. So can you see here how you've got a high inspired CO2 level? The Sodalime has run out. So if you increase the flow rate, so remember we said that a flow rate of 5 to 6 litres is what we normally do for patients. If you increase that up to, say, 10 litres, can you see here how the inspired CO2 level is slowly dropping down? And the reason is because you're flushing out more of the system. Now, this is less efficient for the ventilator, and if you're using a volatile anaesthetic, you will consume it a lot quicker. However, what you can do by increasing the flow rates is flush it out and buy yourself a little bit of time until you change your Sodalime. Now, I alluded to this at the start, but anaesthetic machines are different in the way that they work compared to intensive care ventilators. And so giving supported breaths at spontaneous ventilation is very different. So if you do see pressure support on anaesthetic machines, especially the older ones, be careful, because it's not quite the same as the pressure support that you get in an intensive care ventilator. Of course, they're both, in theory, the same thing. But with the bag-in-bottle type ventilator, so the bellows ventilator, there can be a lag between the patient taking a breath, the ventilator thinking, oh, he's taking a breath, and then giving a bit of support because of that lag in actually pushing those bellows down. So it's not as efficient, and the time when a patient wants the maximum support with their breath is at the start of the initiation of their breath. And so you can get a delay, and that delay can cause dyssynchrony between the patient and the ventilator. So in general, what I would suggest is don't try to wean people on an anaesthetic machine. If you're finding that patients are improving, see if you can swap anaesthetic machines for an intensive care machine, just to give them a little bit better ability to wean. And anaesthetic machines aren't quite as sensitive as the intensive care machines. They're not quite as clever as intensive care machines. So you can get what we call auto-triggering, where the ventilator thinks the patient's taking a breath when really they're not, and it tries to give a bit of additional pressure support. And so patients can start looking very uncomfortable if they're trying to breathe and they're being given pressure at the wrong time in their respiratory cycle, or the ventilator may think that its patient is breathing when they're not. So to try and reduce the chances of auto-triggering, you want to try and decrease the sensitivity with which the ventilator says, oh, this patient's taking a breath. And what I generally suggest is using a trigger of 3 litres per minute to suggest to the ventilator that the patient is taking a breath in. The one thing I would say about setting this slightly higher trigger level of 3 litres per minute is that patients who are weak, and certainly those patients who have been on intensive care for long periods of time, may not have the intercostal and diaphragmatic strength. They may not be able to generate 3 litres per minute. So again, these patients shouldn't be weaned on an anaesthetic machine. We should change them around to an intensive care machine. Final thing to just know is there are a few buttons just not to touch on an anaesthetic machine. With an anaesthetic machine, there are a couple of switches that you don't really need to use. The first is what we call the common gas outlet, and it'll look something similar to this. Now you can see here, you can turn this dial up, and when you dial it up, it goes into the ventilator. So this is the ventilator tubing. So this will go through the gas will go through the ventilator tubing and into the patient. If it's turned down, what happens is all of the gas that's in the anaesthetic machine, instead of going through the ventilator tubing, will just come straight out of here. The reason we have this in anaesthetic machines is sometimes we want to put in an additional type of breathing apparatus, especially for children, and so we use this common gas outlet. But for you, do not touch this. Make sure it is always in the ventilator side, and don't do anything with it. Don't touch it. Similarly, on an anaesthetic machine, we have a switch that looks a little something like this. So it switches from the ventilator. If you pull it down, you'll be able to use the bag to manually bag a patient. Again, for intensive care patients, it is not that common for you needing to bag the patient. And if you do bag the patient, I would suggest doing the usual things with a water circuit. This can be used as a corollary to as a substitute to a water circuit, and that's how we use it in anaesthesia. But again, if you're having to bag patients, I would speak to the physiotherapist, I would speak to the intensive care doctor, the anaesthetist, and they'll be able to help you. But for day-to-day, I would not touch this. And the APL valve is only activated when the switch is turned to the hand valve, and it's similar to the valve that you see on a water circuit on the top, and just increases the amount of pressure for each breath. But in general, keep it switched to the ventilator and don't do anything with this. So in summary, the main thing to say is ITU ventilators are not the same as anaesthetic machines. If you're trying to set gases, look at the gas sensors. Don't look at what the screen says. Look at what the inspired oxygen is and the expired oxygen is. Look at the inspired and expired CO2. Those are the things that will guide how you manage the patient. Things to be particularly aware of with anaesthetic machines are the HME and flooding of that, or leaks from it. Looking at the flows, generally speaking, you want to keep a flow of 5 to 6 litres per minute or 50% of the minute ventilation. Always keep an eye on the bellows. If the anaesthetic machine has a bellows, make sure that it's got that bellows with a rise up to the top of the bottle at the end of each expiration. If it's not going all the way up to the top, there is a leak somewhere. Have a look at your circuit, check the endotracheal cuff, check the endotracheal tube. Make sure that there's nothing leaking anywhere in that system. Anaesthetic machines use the circle method of providing gas, so patients will be rebreathing the gas that they've already breathed out, and as such you need something to remove the CO2. Sodalime is that thing. So if you see that the amount of carbon dioxide being breathed in with each breath is starting to go up, or you see the PCO2 starting to go up on your blood gases, always think about the Sodalime. Does it need to be changed? Beware of pressure support on anaesthetic machines. The very new anaesthetic machines are probably analogous to intensive care machines. The older ones, and especially the ones with the bellows, I would suggest are not the same as pressure support that you're getting, and there can be quite significant lags in providing that additional pressure support with the patient's spontaneous breath. So if you're weaning patients, try not to do it on an anaesthetic ventilator. And finally, there are a couple of switches just not to touch. They're not really needed for intensive care ventilation. The common gas outlet and the switch from ventilator to manual are probably not things to touch on a day-to-day basis. And if you are needing to use it, then speak to an anaesthetic doctor or intensive care doctor or physiotherapist before doing that. I hope that's useful, and if you've got any questions, please put them in the comments section below. If there's anything that I've missed out, again, let me know and I can make a second video with additional information. Thank you very much. If you like this video, please like and subscribe to the channel just to keep it viable, and hit the bell notification. There'll be lots of updates coming on a almost daily basis, hopefully.